people are starting to talk like they think that S-ketamine treatments work better if you come into them 24 hours or more fasted. I was taught like all the way back in residency that there was actually a hypothesis that if an antidepressant drug started to work, it's not that it caused suicidal ideation, but that they still felt suicidal, but now they have some energy. Like that was the whole, hypothesis, that they were so depressed they couldn't make a plan. And then congratulations, you gave them a pill and they got just well enough to do the thing. In one of the most embarrassing moments of my career, he takes a look at this lab number and then he looks at me and says, if this number was correct, we'd be up to our ankles in blood. And at the time, I felt like I was the only one telling my residents that patient with severe depression that we just brought into the hospital, their brain is dying right in front of you.
All right, William, it's good to have you back again. I haven't talked to you in a little while. You're still out in, correct me if I'm wrong, I think you're like Virginia, North Carolina, somewhere, and I can't remember exactly where you were. What part of the country are you in again?
So it has been a while. I'm still in Virginia, but since I talked to you last, I moved way up into the hills.
You moved up into the hills. Are you escaping something?
I'm up in the Shenandoah Mountains now, a little bit west of Charlottesville.
Okay. How do you like it up there?
I love it. The animals escalated quickly. So
say that again.
The animals escalated quickly. So now I'm surrounded by chickens, ducks, a couple of emu, cattle and horses that aren't mine, which are the best kind. Someone's renting my pasture. But the latest news is that the emus laid about 10 eggs, and we're actually maybe expecting them to hatch just about any day now.
Oh, you're not going to eat the emu eggs then?
No, people keep asking me that. I think the number one reason why I probably wouldn't eat them is that they only lay maybe 15 eggs at one time of year. So in general, you'd get one giant omelet about once a year and then you're done. So they're not super valuable for the eggs for eating, but I don't know if you've ever seen little emu chicks on YouTube, but they are absurdly cute.
I have not seen emu chicks. I know this is interesting that people that develop alpha-gal meat allergy have been known to be able to eat emu meat. It's supposed to be, because I guess it's a dark meat. I don't know. Maybe you don't know because you haven't. I don't know if you.
Yeah, I've had it before. I've had emu and or ostrich, and it's reddish. It was a long time ago I tried it. It was super lean. I wasn't that crazy about it, but it is more of a reddish.
It is tend to be lean. Yeah, that's the one negative about that. But I've seen people that have said they've been able to have emu or ostrich for that matter. There are some ostrich growers in the U.S. that sell their meat. So what prompted the move up to is that something you wanted to do, start a little farm or something like that? Was that what caused you to do that?
It was. My wife especially she's dreamed of moving up into the hills for years. And she always used to talk like Montana, Colorado. She'd fallen in love with the Rockies. And then one day, for no reason, she woke up in the morning and decided that 9 months of winter wasn't her favorite idea. And she changed her ideas of from west of the Rockies to west of Charlottesville. why don't we just look in the western portion of Virginia? And then the silly market in 2021, I'd sold my suburban house. We were renting a place, just no plan, and stumbled across this property. It really is. It was a godsend. It's watered by a spring up in the Shenandoah. It's super accessible, but it's 35 acres and 100-year-old farmhouse. I just couldn't believe how perfect it was. And we had the chance to jump on it. So way ahead of when I thought this was actually going to happen. Now I really am up in the hills and eating my own eggs.
Well, that sounds wonderful. Someday I have dreamed someday getting out on a ranch or something like that, and I have my own cows, so I can feel a little more. I feel nice when there's cows around me for some reason. It's a better feeling for some reason.
But are you going to feed them macadamia nuts? That's the question.
Oh, like Leberg's doing out there in Hawaii. Yeah, it's interesting that he's doing that. At least he's not eating bugs and trying to. I don't think anybody really wants to eat that stuff, but. Let me ask you, so how does that impact what you do as a living? Because obviously you had to change somehow you practice, unless you're driving all the way back to where you were working before.
I'm driving all the way back to where I'm working.
So, how long is that? How long is that?
I still cover kind of multiple offices, and I was able to consolidate the offices a little bit. So now, ever since I moved, I come to our Richmond office 2 days a week. And I go to our Charlottesville 2 days a week, so that The Charlottesville office is like practically what most people would consider a normal commute. It's about 35 minutes from where I live. To come to Richmond, where I am today, is about 90 minutes. So it's not the greatest. I keep up with my podcasts.
Yeah, I was going to say that's one time I don't listen to a lot of podcasts typically, but if I'm driving a long ways, I'll sometimes do that to keep your mind occupied, I suppose, particularly if you've got a long trip like that. But yeah, I guess a 90-minute you could get through a couple decent podcasts on that a couple times a day. So probably getting more educated. So I guess is there a particular topic you want to get into today? Because I know you've been doing sort of dietary stuff and you've been impacting the brain in different ways, but what kind of stuff do you want to chat about today?
Yeah, I don't know if I had anything exactly in mind in particular. I am going to the Metabolic Health Summit in a couple weeks. So you're definitely right about that. That's my main interest.
Florida, right? Is that in Florida?
Yeah, Clearwater.
Okay, yeah.
Which, interestingly, I didn't think of it until I saw the emails, but low carb was in Boca like just last week. So I'm wondering how many people are just staying in Florida for the whole 3-week stretch, like go to low carb Boca and then just slide right over to the Metabolic Health Summit.
I don't know. I hadn't planned on attending either of those. Maybe one day I'll get an invite to speak at one of those conferences, but, yeah, I mean, I know some people that have been there, and I've talked to people there, and it's just been a pretty good information, and we're getting more and more data that comes out that is showing the effectiveness of low carb diets in general with regard to just a whole host of conditions, whether mental health conditions or because we were expanding out from the sort of the cardiometabolic diabetes realm into other things. And I know Dom D'Agostino and some of Chris Palmer, George Ede, and some of the others have really been driving the benefits of mental health with regard to ketogenic, low carb, even carnivore diets. And so I think that's a good development because I'm sure you've seen people that have dramatically changed their life with diet, I assume. Correct?
The ones that I can get to do it, yeah. That's still actually been the hard part. But where that's of particular interest to me, I have a small number of patients who actually have been willing to take the plunge and make some changes in their diet. Now that we've taken on S-ketamine in addition to TMS, I think maybe the last time you and I spoke, I was 100% TMS guy. And now I'm like a 50% TMS guy and a 50% S-ketamine guy. Both of those treatments are predicated on excitement in the brain. And it would make sense that neither of those treatments can really work well if the brain isn't getting a sufficient amount of fuel, a sufficient amount of energy. And in respect to Dr. Palmer's book, for years, I've had maybe about 25 to 30% of my TMS patients who are like literally tired. I've even heard stories of people slurring after 20 minutes of TMS treatment. And now, most recently, I had a breakthrough with a patient last week who does S-ketamine, and she had actually heard on a forum that people are starting to talk like they think that S-ketamine treatments work better if you come into them 24 hours or more fasted, which is interesting. So that does dovetail to me that, now if you're going to block the NMDA receptor, disinhibit glutamate, try to, induce BDNF, neuroplasticity, and everything that ketamine, S-ketamine is supposed to be, I'm not sure how well it will work if you're like severely insulin resistant, hyperinsulinemic, can't generate ketones, can't get extra fuel into the brain.
Yeah, I think it's interesting because you see reports of various, I guess, alternative treatments, whether they're stem cells or some of these other psychedelic drugs or ketamine and things like that. And the data's mixed on that. But I wonder if it's dependent upon having a properly nourished brain. And I think that does have a big role in the efficacy of these things. And with S-ketamine, because I assume is that just a stereoisomer, one of the L and S ketamine, or D, is there a D version of that as well? I'm assuming that's where that comes from.
There's S-ketamine and there's R-ketamine.
Yeah, and that, or L and D or S and R or something like that. Yeah.
And I think the big difference
organic chemistry from many years ago.
And never was it your specialty, but do you remember like Celexa versus Lexapro?
I do. Yeah, I do.
Because that was kind of an escitalopram, but right. I think it was Forest Pharmaceuticals that had that. They back when they came out with the escitalopram, they argued that our citalopram was inert. And so they isolated escitalopram, threw away the arcitalopram, said it was never doing anything for you anyway. To this day, I'm not really convinced that worked out the way that they thought, because people are still using citalopram and escitalopram interchangeably, right? They're just making the dosing adjustments, and now they're both generic, and nobody really cares. But what's interesting is I've not seen a single piece of literature that suggests that S-ketamine and R-ketamine actually have any different properties. And I even read maybe as recently as 2 years ago that R-ketamine was being looked at for therapeutic use. And then I never heard another thing about it, which, that either means the work continues or it means it flopped. But the thing that makes S-ketamine special, to be super cynical, is that it can be patented. So that's really the only difference. Is S-ketamine is actually FDA approved for depression since 2019. So it's got a brand name and insurance will actually cover it. Whereas you want ketamine infusions, they work wonderfully, but that's 99% of the time that's a cash proposition because it's not FDA approved and it never will be.
I remember using ketamine. The only time there's a couple of times as I was training, I worked in a burn unit and we would put these kids under ketamine to be able to change their bandages because it didn't depress respirations, and they had this weird eye twitching, dissociative type of thing or environment where you could change these horrible burn bandages. And then, of course, a lot of the chronic pain doctors were using it as a pain medicine type situation. But the indication you're using it for is primarily for depression. Is that what you're using it for?
Depression, yep. And it's FDA approved for depression. And then the interesting thing is that it's also FDA approved for depression with suicidal ideations. And the reps from the manufacturer, Janssen, they always have to come around and remind everybody that it's not actually FDA approved for suicidal ideation. So they got to give you the big warning, like this is not a substitute for the emergency room or anything like that. But the reason why it's got that like MDD plus MDD with SI is because they did the trials for it in an inpatient setting, so they didn't exclude people with suicidal ideations from the trials. So that's one of those fun facts that I'd say 90+% of antidepressant medications are actually tested on people who aren't really very ill, because they do it as an outpatient thing, and anyone who's really severe and maybe needs to be hospitalized, they all get excluded. Suicidal ideations, they all get excluded. But this one they did inpatient, so they kept them all in the study. So I think it might actually be the only FDA-approved antidepressant agent that's got that, is actually FDA approved for depression with suicidal ideation moniker.
Yeah, I know a lot of these different drugs that have been approved for depression over the years have, in some cases, there's concern that they've actually increased suicidality in some situations. And so that's probably why they have this with suicide ideation differentiation, correct?
And I don't think anyone's ever answered that question, right? It basically became a class warning. And this is, I think that happened maybe before I was in medical school, right? So if I graduated from medical school in 2000, I think, would you say that warning came around like maybe in the 90s or something like that?
Yes, as long as I can remember. So it was before probably. Yeah.
Back in your day. Happy birthday, by the way. I think you're a grand total of 7 years my senior. So
I'm 57. So did you just turn 50 then? I'm 57.
I'm going to turn 50 in September.
Okay. So a little about 7 years older. Yeah. Yeah.
So so as long as you can remember, now that I was taught like all the way back in residency that there was actually a hypothesis that if an antidepressant drug started to work, that the patient with depression, it's not that it caused suicidal ideation, but that they still felt suicidal, but now they have some energy.
Yeah, I've heard that.
Right? That was the whole hypothesis, that they were so depressed they couldn't make a plan. And then congratulations, you gave them a pill and they got just well enough to do the thing. But then there was the class warning for adolescents. And now there's multiple papers published that I think the greatest fear in the field is that adolescent morbidity and mortality from depression went up because of that class warning. So many doctors were just afraid to treat them at all.
Interesting. Yeah. And I know we keep talking about treatments, but gosh, I hope we can get into the prevention aspect of it, because it's just, I think I talked to Georgie the other day, and I think she said something like now 1 in 3 adolescents, young adults, are now suffering with some form of mental health disorder. That's insane. 1 out of 3 people
Yes.
is potentially needing to be medicated for mental health. This doesn't make sense.
And then it's 2 questions, right? It's like, one, how is it that 30% of the adolescent population, that's a devastating number, to think like 30% of the adolescent population is suffering from depression, anxiety, and then maybe up to and including like bipolar disorder should present later, schizophrenia should present later, but we could include all those things in there. The other question is, how is it possible that the definition of the diagnoses has changed so that we're pulling people in with a bigger net, but then medicating, like that? Do we change the definition of other disorders? I guess just to bring up what everybody talks about all the time. Isn't that kind of what's happened with cholesterol? Like the goal for cholesterol keeps getting lower and lower and lower, which means more and more people technically have hypercholesterolemia, which means more and more people have to be medicated. But it's not.
Yeah, you've seen that with blood pressure. You've seen that actually with glucose. When diabetes, the fasting blood glucose for diabetes used to be 140, now it's 126. Systolic used to be 140, now it's 130. So we're seeing these wider and wider nets cast. So now you're basically defining most of the population as being ill in some cases. And so you can just medicate more people. It gets to a point where the majority of people are on meds, which it just doesn't seem to make sense from a just a common sense standpoint. Why do most people have to be on medications to exist in society? And it just doesn't, it's, we've never lived in a time like that. You can go back, I don't know, before these medicines exist, and people seem to have lived productive, in many cases, very long, healthy lives. And I don't know, we're in a really weird place. And I think it's getting to where people are accepting that. They're being trained to accept you need to be on medications. That's just part of existence. It's not your fault. You're just unlucky. And the whole message that obesity is not a lifestyle issue. It's really just a genetic or some other disease it's not your fault, and therefore just take the pill, take the shot, whatever.
I think I saw that in one of your posts, right? They said it's a chronic illness. Obesity is a chronic illness.
Yeah, it certainly is chronic, and there are illnesses associated with it. But I think the real issue is there are people out there, particularly Dr. Stanford out of Harvard, who sits on the national dietary guidelines panel, saying that lifestyle, diet and exercise have no impact on obesity, which I think is just insane to have a physician saying that, and then also being, of course, sponsored by Novo Nordisk and taking thousands of dollars from that company. And
right.
It's clear conflict of interest. So
it's absurd on its face, right? That since a 50-year-old and a 57-year-old doctor can ask this question, since when do physicians start ignoring obvious things? Because that's what I see.
Yeah, I think they ignore them when it's deleterious to their career to do that.
Yeah, and it makes me sad that you're probably right. But I'm thinking back to what it's like to be trained old school. Right before I got out of the Navy, they sent us down to Haiti for the earthquake, which was probably one of the catastrophically worst deployments I ever had in my entire career. Because we're probably a couple 100 miles from the tip of Florida, and we couldn't get a crate of supplies on our desks. We ran out of masks and gloves within 4 weeks and shut down all our operating rooms, and we couldn't function. But one day on this ship, we're all pulling internal medicine rounds because there weren't really enough people to manage the ward. And we got this gentleman who doesn't speak English, and the pediatrician was the one who was seeing him, and she waved me over because she didn't know what to do. And he's sitting on the edge of the bed. He's in no distress. He actually looks completely fine. But we're looking at the lab value that came back, and one of the coags, it had to have been 10 times what it should have been. If I'm thinking like whatever the number was, if it was supposed to be 10, it was 100. And the two of us, the psychiatrist and the pediatrician, are looking at this. I really don't know what to do now. This number is 8,000 kinds of wrong. And I can't really ask the patient what he thinks about the situation, and we're stuck. And it took about 30 seconds for me to get the attention of there was a Navy captain who was the internist, and he was the unofficial CO of our little group. And I called him over. I'm like, I need some help. And he, in one of the most embarrassing moments of my career, he takes a look at this lab number, and then he looks at me and says, if this number was correct, we'd be up to our ankles in blood. So ask yourself, what do you think is really happening here? And I'm like that, we're looking at a painfully obvious thing. And that was the thing that I was taught to do in medical school. And in that moment, I forgot. I know this number can't be right, because if it was right, everything else in front of me is now patently absurd. This can't be true. So we're going to go back and double check the lab value. That's what I'm thinking about when I ask about these doctors who are the pinnacle of academia and public health and so on in this country. And they say crap like that they're like, diet, lifestyle, and exercise has no contribution whatsoever to obesity. And it's like, can't be true. So that thousands and thousands of years, humans didn't have an Ozempic deficiency. So how could anybody act like somehow the only answer to obesity in humans is drugs that were invented within the last 10 years?
And my medical education, if you look at the stats on that, a significant portions of medical schools get their budget from pharmaceutical companies. They help design the curriculums. Of course, the second you're second year, first year medical student, the drug companies are coming in, they're giving you free pens, and you start to feel they build those relationships to where those are the ones that kind of train you and teach you, and you're trained into that system. And yeah, I mean, you start, and I guess you just, whatever comes out, you think about it. We offload our critical thinking skills to the pharmaceutical industry. They tell us how to think, how to prescribe, how much to prescribe, when to prescribe. I had zero training in how diet could treat disease. It was a factor, a sort of a lip service factor. Yeah, these people have a poor diet or whatever, but we didn't really spend any time on how you could actually manage the disease by significantly altering diet, particularly orthopedic stuff. There's nothing in orthopedics. No one's talking about arthritis and diet. It's, you lose some weight, sure, but it's beyond that. It's pretty minimal. But it's interesting with the way the Ozempic stuff works. I liken it to, it's GLP-1 receptor agonist. So we've got this incretin hormone that slows down digestion. It provides some satiety, and those are the mechanisms by which it works. And that's supposed to normally happen in response to certain nutrition. And interestingly, there's been studies on meat that show that meat actually very well affects and stimulates GLP-1. And so now what we're doing is having that physiologically occurring in a non-physiologic setting. Eating potato chips doesn't really have the big response of GLP-1 like eating a steak might. And so we see people on a carnivore diet where they naturally feel satiated, their digestion does slow down, and that's supposed to occur. But now it's the analogy I like to use is, if I go out and run some sprints, my heart rate's going to go up, and that's normal. That's supposed to. But if I could sit on a couch and inject medicine to make my heart rate go up to the same extent,
right?
No one would say that that's of benefit to me, right? I don't think there's anybody that would say, we're manipulating your physiology in a non-physiologic setting, and I think that's what we're seeing. And so clearly there are people that will lose weight with this. Long-term outcomes yet to be seen. I know we have the drug company sponsored studies where they will make these claims. Of course, they never show that. They're not required to show their data, which is really bizarre to me. It's the fact that most of these drug companies sponsor trials, their raw data is never available. It's just what their interpretation of the data. So they can hide stuff, and they do, and they've been caught doing that. So we don't know. And so what happens is the onus is upon the clinicians, 5 years, 10 years of watching things, to finally decide to say, wait a minute, we've seen too many negative outcomes. And as you probably know, you've probably seen a lot of complications you never even noticed. There's a lot of things you just don't even pick up, even as a physician. I know people will say, this weird condition I've only seen occasionally, but it's seen me many times, right? A lot of times we just miss these things because we're just like, I wasn't clued into it. I wasn't paying attention to it. But it'll be interesting to see how this stuff plays out. And over time, I suspect that class of drug will be around for a while. It'll make a lot of money. It'll eventually be replaced somehow when enough people get sick by it. And we'll see what happens over time.
Yeah, they'll invent something better, in theory.
And that's the model. They maybe run it for 10 years, make $500 billion. Maybe they end up paying a couple billion in fines for the people that get messed up by it pretty badly, and on to the next drug. And there we go. And we still, and by the way, I just look at it right now. You think about how bad the health of this country is right now. And could it get worse? Is it possible for it even to get worse? And I think the side answer is, I think you get to a point where 90% of the people in the population are overweight and sick. We're already at 70% between the overweight and the obese population. Can we get to 90? Can we get to where you're the one guy out of 1,000? It used to be, when I went to school back in the 1970s, we had the fat kid. His name was Stephen Smith. I remember him. Sorry, Stephen, if you're listening. There's a lot of Stephen Smiths out there, but this kid named Steve Smith, he was the fat kid in the neighborhood. There was only one. There were no other fat kids. And he was it. And it was just like it was like an anomaly. And today we've got almost 25% obesity rate in our kids. So it's amazing how that's turned out.
I think you make a great point, because for reasons I can't imagine right now, that was in my head. The same thing when I was a kid, and there was one, and I don't remember this boy's name, but what I remember was really being chewed out by my mother for making fun of this boy in my class who was that one fat kid. And to be fair, he was picking on me, and I just chose that as a cheap way to lash out at him for his behavior. But the psychiatrist in me, points out that when we were kids, I would argue that it was extremely natural for children to make fun of and be cruel to the overweight kid, because that kid was an anomaly. So you would argue that in normal tribal social behavior, it's like the kids are always going to want to gang up and pick on that kid that they're not used to seeing. So you see something that's different, and your immediate assumption is to reject that. And then your wonderful parents have to be the ones to sit you down and say, we don't make fun of kids for things like that they probably can't help, and it isn't their fault. But how does it change society when 3/4 of the class are now the obese kid? Where we could be heading towards a future where the thin kid's the one that gets picked on.
Yeah. Why are you so scrawny, man? Eat up. You need to go get some of these damn Twinkies in you, boy. Yeah, it is. It's not that you're advocating picking on these anomalous kids, these kids with some disability or weird physical feature, it was considered very bizarre to be overweight years ago when I was a kid. And now it is pretty normal. And yeah, you shouldn't pick on people because they're different, clearly. But at the same time, and I see that. We see that in the adult version, where you have these 20-something-year-old people that are morbidly obese. And they're literally 400, 500 pounds. And then they're sitting there saying, we demand to be a society to accommodate for us. We demand more seats on a plane, or bigger restaurant chairs, and we demand to be heard, and on and on. And part of me, I understand some of that, but at the same time, then you see them dropping dead by the time they hit 40 or 37 or something like that. And so are we, I think in a way, when I was practicing orthopedics, people would occasionally come to me wanting a mobility scooter, because they had a bad knee or a bad back or something like that. It was difficult for them to work. And I always told them no, because I felt that would eventually make them worse. I felt that this was just basically my thought. I viewed those things as mobile coffins. Now, because I always felt that there's something they could do to improve that situation. If they didn't have some ALS or some advanced neurological degenerative order where they're paralyzed or something like that, I always felt that, hey, we should be encouraging people to get strong or get active. There's things you can do in that situation. So I never wrote for a mobility scooter, and somebody else would. They'd go to find some other doctor that would do that. But I think in a way we've created this, because if all the doctors said no, like, it's interesting in Japan, it's fascinating here. The obesity rates in Japan are incredibly small. It's 4% of the population, extremely small. There's some sumo wrestlers. But beyond that, if you're obese in Japan, they don't have clothes for you. They don't even make clothes for you. I mean, you're going to be walking around in a bed sheet then. But in the U.S. now, you go to the store and there's size 6X, 5X, anywhere. We've accommodated this so much so it allows it to happen. It's like having a fish in an aquarium. If you have a small aquarium, the fish only gets so big. But if you expand that, the fish get bigger and bigger. And so I think we've just basically literally created the healthcare system in a way basically allows these people to still exist, and it almost creates it. And I don't mean that they shouldn't exist, but I'm just saying by providing them mobility scooters, by providing them all these medications, portable oxygen tanks where they need that. Yes, we don't want people to die, but at the same time, if those things weren't available, they would either have to make a decision that, hey, there's no more accommodation here. I need to physically make the changes, which I think most people could do, but often just it's easier just to do the easy thing, which I think is unfortunate.
I think you're right that in psychiatry, I think I was forced to think about that really early on in my career, because it's to virtue signal and maybe flatter you a bit. What happens when you take morality out of medicine? If you're not really worried about the morals of taking care of people, then a lot of times it really is just easier to facilitate their illness. Right? And that I first started ranting about that in psychiatry because I noticed early on that people with depression, even in the hospital, they got very slow, very lackadaisical treatment. Everyone's attitude towards a depressed patient is, here's an antidepressant pill. I'll ask you about it in 6 weeks and we'll see what happens and maybe we'll think about another pill. Meanwhile, someone with schizophrenia, that's a frickin' 4-alarm fire in the emergency room, and they get both barrels treatment, and we treat it like it's this massive emergency. But the reason why we do that, it's not because of the welfare of the patient. It's that the psychotic patient is a problem for everybody else. So everybody is scared, and therefore we all come rushing in like it's a giant fire. A patient with depression, they sit in the corner and don't really cause anybody any problems. So nobody's really worried about it. And I felt by the time I was teaching residents in San Diego, there's got to be other people that did the same. But at the time, I felt like I was the only one telling my residents that patient with severe depression that we just brought into the hospital, their brain is dying right in front of you. Like they are in a very severe illness state. And the fact that they're not causing a problem is not an excuse for us to not come at them just as aggressively as we would anybody else, because we got to get them well because we're watching them die. And that, I think what you're talking about, where it's easier to make doors wider and it's easier to give someone a scooter, it's easier to change the structure of the world to accommodate somebody. But if you do that as a physician, all you did was make it easier for someone to die.
Yeah, you facilitate their illness. And I had patients, I can remember one time I had a patient complain about me because she was obese. She wanted a cortisone injection in her knee, and she had been gotten over the years in the past. And I said, look, this is actually damaging your knee over the time. And I think we should really have a discussion about overall health and lifestyle. And I ended up not giving her cortisone injection. That's what she wanted. I said, no, I think the better option would be to work on some of these other things. And so she went and complained to the administration. They got her an appointment with somebody down the hall who gave her injection. And I was just like, there you go. It's just, this is the sort of thing, you're trying to do the best thing for them. And as much as I complain about the healthcare system and the fact that we have a system that's designed for the quick fix, the magic pill that isn't really a magic pill, we have a lot of patients that expect that, and they don't want to, like you mentioned earlier in the discussion, when I can convince somebody to change their diet and lifestyle, then it's quite powerful. But we're still at a point where most people, we've basically been trained. People are trained, when they go to the doctor, they are going to get a pill or something. That is what the patients have been trained by that. The pharmaceutical people is trained out. We have this direct-to-consumer advertising. Ask your doctor if blah, blah, blah is right for you. They're going in there with the perception that they need a pill. And when you come in there and say, I don't think you need a pill, I think you need to stop eating poison, that's not their expecting. And then when they get that, they're upset about that because they thought they were going to get a pill. And so it makes it very hard to practice as a physician, even if you want to do the right thing. You've got this expectation. And I think that's where we're going to change that. And like I said, I know I've talked about Revero in many cases, but the patients that will come to us. And the one thing that's nice about where I'm at these days is because when I was practicing orthopedics, people that came to see me did not want to see me. No one wants to come in there with an orthopedic. Nobody wants to come there with a broken ankle or a broken elbow or a rotator. They had to be there. They came to see me because they had to, not because they like me or anything like that. And I did my best to try to fix them in the capacity I do. But today, people come to see me because they want to be there. They want to make that change, that they know what they're getting from me at this point, and which I think is cool. It makes practicing in the capacity that I do now so much better because I've got somebody that wants to make a difference. I don't have to cajole them or try to convince them that they need to make a change. They already know that. And so now it's just giving them the tools to do, which is, from a reward standpoint, it's orders of magnitude better. It's always pleasant. Yeah, man, we're gonna actually fix you and make you a lot better, or at least do our damnedest to try. So anyway. So let me ask you a little about, you said TMS. Remind me of the TMS again. That's
transcranial magnetic stimulation.
Yeah. Okay. What is this? I know because the last time we talked about it, there was still discussion about how it's being. Has that changed much? Is it still being? Because you said you're half and half ketamine versus the magnetic stimulation stuff.
Like fundamentally, nothing's changed, which is frustrating. Right, so TMS, FDA approved in 2008 for the treatment of depression, and bread and butter TMS, we're still doing essentially the same treatment with the same equipment. There's been a couple little doodads changed here and there over the years, but an interesting development that this is weird because the treatment protocol was FDA approved, but the equipment to do it doesn't actually exist. So we're in an interesting situation now, but there's a new way to do TMS that is called SAINT. Did you hear anything about that?
No.
And the S in SAINT stands for Stanford. There's this really young superstar named Nolan Williams, who's a guy out at Stanford that he's published some absurd number of papers in the last 4 years, and involves the S is for Stanford, the A is for accelerated. I can't remember what the INT stand for, but it has to do with using a particular way to do TMS where you can do it faster. So there's the normal way. The original 2008 way to do TMS is 10 pulses per second. So 10 nerve depolarizations per second, 4 seconds on, now 11 seconds off. This faster way is called theta burst, where it's a 50 hertz triplet happening at 5 hertz. So think like a carrier wave. And it fundamentally enables you to do about what you can do in 20 minutes in about 3 minutes. So it's not better, but it takes that 20-minute treatment, compresses it way down. So then Nolan Williams took that and proposed for SAINT that we could do 10 treatments a day. So one theta burst treatment on the hour, every hour for 10 hours for 5 days. 50 treatments in 5 days. He also did it in a functional MRI guided way, which I personally think he's still trying to prove that actually matters, that if you can use fMRI to like really get your coil placement down as opposed to just using like gross anatomical landmarks. But ultimately, small studies, 20 people, 30 people, 40 people, but they're showing like 90% efficacy, maybe even like 80 to 90% people getting into remission in 5 days from severe depression. So that if the equipment that enables the regular practitioner to do it, so like right now, if you want to do that treatment and you want to do it with the fMRI and everything, you basically have to be in an academic center where you have about 3 different pieces of equipment that you put together with spit and uptake using the infrared 3D cameras to translate fMRI data that's been analyzed into positional data on the skull and do the whole thing. But that particular protocol was actually FDA approved like last year. And then there's a company called Magnus Med that is apparently testing out a device now in maybe 2 clinics in California that would actually enable, like in theory, I could get this device when they're ready to release it, and the fMRI data just gets shot right down to the device from the company, and then my patient can go in there and I can just do the treatment. So that might be on the horizon.
And the indications for this are just largely depression. Is that the only indication?
Still depression. So now TMS did get FDA approved for obsessive compulsive disorder in 2018, that's a different coil design, and it's supposed to be It's actually a field that is supposed to reach all the way down to the anterior cingulate cortex. So that's supposed to be the corticostriatal thalamic loop that's involved in OCD, that old thing. So if someone has that equipment, you can do that for OCD, though interestingly it combines a exposure therapy. So you're doing a dumbed down version of exposure therapy for OCD, and the brain stimulation is enhancing the actual exposure therapy efficacy, is supposed to be the idea behind that. And then the only other new development, which actually I haven't talked to you in a while, so that might be since I talked to you. One TMS company got TMS FDA approved for smoking cessation, that is fascinating. And that I'm not under the impression anybody's doing that. That's what this kind of goes back to our very recent discussion about like actually solving problems and facilitating illness versus addressing things, is that using a 5-day-a-week brain stimulation treatment for 3 weeks to help people get over nicotine addiction is, I think, something, as far as anybody knows, insurance is not interested in at all. So that's where that equipment exists and the FDA approval exists, but I think it's been super niche-y, and I might know one guy who's done it once, and otherwise it's just not something that people are picking up.
Since we last talked, and maybe since we last talked, but there was a large paper that came out questioning the whole belief that the SSRIs or serotonin imbalances were associated with mental health disorders, and it was based on faulty data initially. And so there's questioning, because you've got an entire industry of SSRIs, selective serotonin reuptake inhibitors, that are like, why do we prescribe all these things? And maybe there's some efficacy, maybe it's a pleiotropic effect or something like that. Do we have a better idea why depression or some of these mental health disorders are occurring, or is it still, because it's hard to study the human brain, it really is, but
it is.
Where do we think, what's the, I guess, the state-of-the-art thought on depression in 2024?
The state of the art is that I don't think there's really a better hypothesis that has come up yet. I'm definitely on the side that another doc said to me years ago that probably within 10 years, depression will be proven to be a minimum of 5 different illnesses. So like right there, I think we're absolutely positively, the DSM diagnoses are just collections of symptoms. And it's extremely plausible that I have a room full of 100 people that can all be diagnosed with MDD by the criteria. There's no reason to think that they all have the same illness, that it's looking the same on the outside. But I'm so glad you brought up the SSRI thing, because was that a Telegraph article 3 or 4 years ago? There was a paper in the UK, right, that they put that out as that big expose.
I think it came out of the UK, yeah, saying that they believe the original data was skewed some way. I can't remember the details on that. It was
earth-shattering expose when they said that depression is not really a problem of serotonin, according to the authors, that there was nothing to prove that. And I saw that article and I was like, yeah, I was taught that in residency. I found that odd that it was such an expose sometime after 2020, when in 2002, something like that, like during my second year of residency, that was one of our classes. I remember sitting in didactics and we're like, and is depression a serotonin deficiency? And my teacher says, no, absolutely not. And we were taught right then and there that SSRIs work about 30% of the time, and literally nobody really knows why. That, and part of what went into that back then, you take an SSRI, whatever one you want, fluoxetine, just for fun. There is more serotonin available in your brain within probably an hour of taking that first pill that you ever took in your life. It's like you take the pill, the first thing that's going to happen is it's going to inhibit the reuptake of serotonin in your GI tract. So there's going to be more serotonin, which might make you feel nauseated or even throw up, because that's literally what serotonin is for, in your GI tract. And then it gets in your blood and it increases serotonin. Right then and there, this goes back to my point about the weird coagulation labs. If depression was a true serotonin problem, you'd feel better the afternoon that you took your first fluoxetine. That's not how that works. It's like those drugs take at least 6 weeks to kick in. Now, when you take serotonin reuptake inhibitors, the downregulation of the serotonin receptor coincides with that 4 to 6 week mark. So again, going all the way back to 2002, we were taught those two things go together. And my classmate said, then is that it? Is there something about downregulating the serotonin receptor? That's what actually is a therapeutic effect for depression. And my teacher, of course, very importantly said, well, you can't prove that. We're like, those two things just happen together. And then SSRIs seem to have impacts in the cells, like all the way down to the genetic level. SSRIs induce BDNF. They induce neurogenesis and the dentate gyrus. They induce neuroplasticity. And literally nobody can tell you how any one of those things equals resolution of depression in 30 to 35% of the population, which is about as good as the efficacy gets. So my question when that article hit the news and everyone was so excited about it is that I haven't thought that depression was a chemical imbalance in 25 years. And I was surprised to find out that anybody did think that. I even emailed my old residency pals and they all agreed with me. They're like, yep, that's exactly what we were taught back then in residency. So it's strange to me that this chemical imbalance thing continues. And not only does it continue, it's so widespread that this article was seen as an expose in 2021 or 2022.
Maybe we've discussed this before. I know I certainly have talked about it. I know there was a study in 2018 out of Stanford looking at carnitine levels, and there was a real clear link between low carnitine levels systemically and major depressive disorder. In this carnitine you get basically from meat, animal products. And I don't know how much weight that study carries, but it seems to me I see a lot of people who get healthier mentally, including depression, by going on a meat-based diet. And I just wonder if that's the mechanism by which that occurs. I'm sure there's obviously you mentioned there's lots of things going on in the brain, whether it's iron and zinc availability and on and on. We could probably postulate on a lot of things. But were you aware of that thing about carnitine?
I was. And frankly, I was probably aware of it because of a post from you. So thank you. It's like that. If you posted that when you saw, that's probably how I saw that. I think that's very plausible. And it goes back to your really wonderful question of what I wanted to talk about today. But Dr. Palmer's Brain Energy, I knew what was in that book because I'd seen a couple of his lectures before, but that's probably one of the things I'd actually say changed my life, thinking about mental health in terms of how it is you get energy to the brain. With all that context, I think it's extremely plausible that like carnitine has such a big role in mobilizing fat for energy. And mobilizing fat for energy is probably the only way you can really support the brain's energetic needs. Like that, really. People are so carbohydrate dependent in the United States that they get hangry every 2 hours. Right? Because if their blood glucose starts to fall even 1 iota and there just is no ability to mobilize fat for fuel and the brain starts screaming that we're going to die in the next 15 minutes because our blood sugar is starting to flag and people are having this terrible time. I can almost imagine how if carnitine was the thing that was missing, not only would you see an improvement in like cognitive ability, which is going to have a huge role in someone's ability to manage their mood and manage their thought process. Like not only is something like carnitine probably going to be helpful, but I think it would be helpful very quickly. So
yeah, that makes sense. Yeah. And I think we also see that if we carried on, and I had a nice discussion with George about this, the fact that so many people with dementia also have depression that's often predates that. And so it may be the same whole brain energy situation going on, whereas dementia is just a farther down the road symptom of lack of proper energy and nourishment.
Yes, and that I'd go even one further and say I think anxiety is even the bigger one, and that this again goes all the way back to our training. I was taught all the way back in school, the earliest presenting symptom of dementia is anxiety. And that was so when there was a paper quite a few years ago, right, all the way back when I was in training, that associated benzodiazepine use with dementia. And that started the big hoopla that apparently 3/4 of Florida is getting started on Ativan, and then they all get demented. And the horrible benzodiazepine use is causing dementia. And again, one of my very wise professors just looked right at me and said, "What's the first presenting symptom of dementia?" And I'm like, "Anxiety." He's like, "So what do you think that study means?" It's like everybody goes to their doctor and they say, "I'm anxious." And instead of doing a cognitive battery, they just give them Ativan. And then 3 years later, they start having the other symptoms of dementia. It's like they always had dementia. And when you put that in with nutrition, if you were inclined to be even slightly anxious, you don't strike me as someone who is, but let's pretend for the sake of conversation, and I were an evil supervillain who really wanted to wreck your life, the only way I can think of to make your anxiety worse would be to take away some of your cognition. Because now, not only are you a little bit fearful and hypervigilant, but the whole world moves 15% faster than you do. So that's, of course, your anxiety is getting worse and worse and worse as your cognition is fading. And then all these things we already know, right? If you are insulin resistant, there is I want to say it was a convergence EEG study, but there's imaging evidence of cognitive impairment that is detectable well before age 50 in the context of insulin resistance. It's like right then and there.
Yeah, I've seen that. The dementia starts showing up even in the late 30s, early 40s. We can probably get an idea of people that are on that pathway towards dementia. And it's not genetic or related to ApoE subtypes 3, 4, whatever you want to call it. But there's some of that. But we're seeing on fMRIs, functional MRIs, where there's dementia that's showing up early. Not everybody, now most people don't do those because it's not something you're thinking about, but it might be where we can start picking up as other tests come out that, hey, you're already getting dementia and you're only 32. We better change something. And
exactly.
Like you said, probably a lot of people that were on that dementia pathway were medicated with anti-anxiety meds, depression meds, and really were watching their brain basically deteriorate in front of us.
Yeah, because that's what they complain about. And that once I read that paper, every time I go to Costco now, I realize that the people that are in my way with their giant carts that are moving so slowly through the store, it's like they're not being annoying, they're wandering. Yeah. Like once I realized that a massive proportion of the over 50 population they're actually probably suffering from mild cognitive impairment. So that walking around in the grocery store, touching literally everything, it's like that's a wandering behavior. And once you see it, you can't unsee it.
I'll have to look at that next. Because I'm usually, if I go there, I'm just zoop back to the store, grab a pack of steak and zip right back out. That's usually maybe I get some eggs or something like that. Maybe a few pieces of cheese.
Now I put it in your head. You're welcome.
Yeah, awesome. Will, I've got to go. I've got to head to other appointments. Wonderful talking to you again. Keep up the good work. Where do people find you if they want social media, if they want to book an appointment or something like that? Where do they go?
At WILYLIAM, and that they'll find me on Instagram, they'll find me on X.
Perfect. All
Twitter,
right, man. Well,
all that stuff.
Awesome. Thank you very much.